Hi, I'm Kathy Ferreira from Stanford University, and I'd like to welcome you to the Immunotherapy other session. I'm going to be co-moderating this with Craig Slingleff from the University of Virginia, and we have a great set of papers to discuss in this session. We're going to be going through one by one, and our first paper was presented by Harshani Ashkar from Oklahoma State University. She presented immunological and therapeutic effects of focused ultrasound in canine cancer patients using ultrasound guidance. So we have one question in the chat, which is, were there any adverse events or off-target impacts of the 50 to 60% ablation regime? And did this vary with tumor type?
So that's a great question. We did not see, since our treatment, like the area of treatment was not very large, we did not see a whole lot of side effects except for some discoloration of skin. And yes, it did vary according to tumor type. So highly vascular tumors would show a slightly larger area of skin discoloration.
I have a question. It's very challenging setups. Were there any exclusions based on difficulty of reaching a particular tumor or being able to maintain anesthesia? Are there any considerations that you would recommend in planning studies?
Yeah, so another great question. So we did stay away from tumors that were very close to the skull or very close to the rib cage. And also, mostly only topical tumors that were kind of targetable using our system.
I see. Well, thank you very much. We're going to move on to our next talk, which came from Lynn Dengel at the University of Virginia, and she presented a pilot evaluation of focused ultrasound ablation plus PD-1 antibody blockade in advanced solid tumors. You know, I have a similar question, Lynn, for you in terms of protocol and patient selection. It seems like a challenging set of indications. Is there any need to exclude based on immunologic status or location of the tumor, that sort of thing?
So for all of our patients, we obtain an ultrasound prior to treatment by Dr. Codd, who's my co-investigator in this study. And she assesses not just the focused ultrasound requirements as far as the distance to the tumor, et cetera. She also looks at the patient positioning and ensures that she can adequately position the patient comfortably and safely during the procedure itself. And we've only treated 3 patients thus far, but the treatment, because we're only ablating about 33% of the volume, the treatments are actually fairly rapid. And as Dr. Shah was just saying, very well tolerated and really very minimal sedation. So I think that's really helped us in terms of the volume that we're trying to treat, creating a short duration of treatment.
Then just quickly from the chat, there's a question as to whether different cancers may respond differently to FUS, and how do you plan to address this, given that you're treating several types, and you want to be able to differentiate between responders and non-responders?
Absolutely. I think, this study is a pilot study, and so I'd love to be able to answer that question from this study alone. But our real primary is to obtain safety information, and then secondary, we're going to look at CD8 response, CD8 infiltration into the tumor, and really hope that these data can inform future studies along with the other correlative immunological studies we're going to do on these patients. Yes, it is a very diverse patient population. I think it'd be really hard to draw really powerful conclusions about the different tumor types, because already in 3 patients, we've treated 2 different types of tumors. So we probably will only have 1 or 2 from each type of tumor that we treat.
Thank you so much.
Thank you.
Yeah, thank you so much. Okay, so let's move on to our third speaker. And our third speaker actually had 2 talks. So our third speaker is Avinash Sharanki. His first talk was entitled Immune Sensitization and Therapeutic Impact of Boiling Histotripsy in Refractory Murine Neuroblastoma. And the second talk was entitled temporal dynamics of intratumoral immune cell infiltration triggered by boiling histotripsy. So perhaps we could open for questions on both. And we do have questions in the chat. So first, there's a question: in your monotherapy and dual therapy assessments, did you look at more chronic time points to understand if or how a T cell response is sustained within a relevant window of adaptive immunity?
I think in this particular study, we did not. I think we essentially assessed 3 time points just after boiling histotripsy and 3 time points after the last dose of the combinational therapy. But that's something that we are currently pursuing, and I think that needs to be well understood to basically then understand the more adaptive response that is either anti-tumoral or pro-tumoral. And so that's something that we are out after.
There's a similar question in terms of why such a dynamic variation in CD4 and CD8 is present only 1 day after boiling histotripsy, but return to the basal level. Can this explain the response to treatment?
So we think that the particular antibody that we used in the immunohistochemistry could be staining even for gamma delta CD8 T cells, and so those are types of T cells that can be more acute. This particular staining technique did not really differentiate the type of T cell or the activity. However, we think that basically I'm trying to understand something in a long term may help us figure out what kind of T cells were going into the tumor.
So I was really interested that you saw a reduction in IL-6 when you added the checkpoints. Did you, and so basically you blunted, it seemed that you blunted the inflammatory response. Is that your general thought?
I mean, the IL-6 did go down after the combination, but interferon gamma seemed to be high at a single time point. IL-6 has a certain pathway that's somewhat associated for certain cancer types to be more pro-tumoral, while gamma interferon on the other direction. Now, to some extent, this is something that we observed. Now, to basically understand this in greater detail, we may try to understand, figure out if we can, what pathways were involved and what does that immunologically mean eventually.
Yeah, I was also interested in the immunohistochemistry in the sense that I haven't seen immunohistochemistry from boiling histotripsy before, I think, but I didn't see much red cell extravasation. Was that consistent, and was that expected?
So in the staining was done on the edges of the treated region to start with, and so cell extravasation. We saw it in certain areas on the edge of the tumor, maybe, but fundamentally we wanted to highlight how does the edges of the treated tumor with boiling histotripsy essentially look like, and these were areas that were always intact. And shown not just by us, but several groups that on H&E that these were well intact tumor tissue or any tissue that it was treated with, so with high spatial precision. So we wanted to understand what kind of immune effects were going on that edge. And so that was sort of the direction. But yeah, this is something that we are continuing to study.
I see. Yeah, thank you so much. I'm particularly interested because it might point to whether or not there would be therapeutic extravasation as well. Just something to look at in the future, something to maybe include in your comments. But yeah, thank you so much. Let's move on to the next paper, which was recorded by Cecile Font. This was paper 8. This was from INSERM and entitled "The Impact of a Combined Immune Checkpoint Inhibitor and Mechanical Focused Ultrasound Treatment in a MC38 preclinical model." And I think, Frederick, you're going to be answering questions for this paper. And we have one first question, which is, what might your data regarding the benefits of FUS first versus PD-1 first imply about the success of FUS for immunomodulation in patients? And I wondered if the effective order was actually significant, or whether, if you did a study of the significance of the ordering.
So we tried 3 sequences, starting with PD-1, starting with ultrasound, or giving the both at the same time. What we observed is that in terms of tumor growth control, we had a better response when we started with the ultrasound. But we also had tumor growth control when we start with the PD-1. But in terms of survival, this is where we had the most significant effect when we started with the ultrasound.
Great. And there's a long question here. Sorry. And yeah, so would you recommend that a specific protocol going forward, or do you feel that it's too early based on your findings?
I think let's say that we don't have yet a clear mechanistic understanding of why starting with ultrasound would be better. We don't have a better understanding than the general idea that the PD-1 is not a starter, but so you need to ignite start the reaction, and then the PD-1 can have an effect. So that's the general understanding.
Thank you.
But yeah.
Thank you. Yeah, thank you. Okay, we'll move on to our next talk, which is Ashish Rajan from Oklahoma State University. Can focused ultrasound enhance the immunogenic properties of doxorubicin and thermodox in preclinical and clinical settings? And so we have a long question here. In the feline study case, there was a stark drop-off in regulatory T cells 4 days post-FUS, but the levels were restored at 7 days. Do you have any hypothesis for this phenomenon?
No, we don't know the reason right now. It was surprising, although clinically the tumors continued to regress for a certain amount of time, and they also came back. So likely there is some compensatory immune mechanisms that are occurring based on that particular tumor type that we were studying.
I see. Thank you. I had some questions about your setup for the mouse. It's very challenging. We've always found it's really challenging to keep the body temperature of a mouse stable when you're doing 30-minute hyperthermia. I wasn't sure of your frequency, and did you have any good way of keeping the mouse cool and maintaining body temperature while you were doing the study?
Well, we did the coupling in the water tank, and the temperature of water in the tank was at 37 degrees C. So there was some control there, but I would agree with you that mouse under anesthesia, no matter where you keep them, they tend to lose a little bit of body temperature. And but they were physiologically all right. They made sound recovery. So I don't think that was a concern for this particular study.
We worry about them warming up because the docs can release systemically. That would be my big worry. Was that a concern, or?
Yeah, that could have happened. I mean, we had 1 or 2 mice in which we measured the core body temperature, and that was close to 37 degrees C. But I would agree with you that there could be some systemic release, especially from the LTSLs, because the transition temperature of release is pretty close to 39. So what we were trying to do for the murine study is understanding the challenges in drug delivery, where to focus more on whether the enhanced local release of doxorubicin with FUS translates into a more systemic immune-related anti-tumor effect, which was evident both for doxorubicin as well as for thermodox, plus HIFO.
Thank you so much. Yeah. And our next talk is from Mohit Singh from Albert Einstein Cancer Center, entitled Boiling Histotripsy and CD40 Activation Resensitize the Immunologically Cold Tumor to Checkpoint Blockade Therapy. And so I have a question.
Sure.
I'm sorry. Hello. What motivated intratumoral injection of CD40? Have you tried other routes of administration to open up the possibility of CD40 interaction with DCs in the lymph nodes? That was my question too.
Sure. It's a great question. So prior literature has suggested that when CD40 antibody is given systemically, it causes lots of liver toxicity. And as we give high dose is required to achieve antigen presentation. And it further increase the chances of getting liver toxicity. And so we try to inject CD40 intratumorally to cut down some of the liver toxicity. And in our prior publication, we found that by doing so, there was no change in liver profile. So I think it reduced liver toxicity.
Thank you so much. Caitlin, last questions here. High intensity focused ultrasound thermal ablation in combination with checkpoint inhibitors for the treatment of refractory murine neuroblastoma was really interesting. You know, my big concern about when in doing thermal treatments is whether or not you could adequately monitor the temperature. So I wondered how you assessed and monitored the temperature in the study.
Yes, that's a great question. So in some of our preliminary work, what we did is create a phantom that produced a color change upon achieving a certain temperature. And so in testing different parameters for hypoablation to achieve similar necrosis that we saw with Dr. Ranke's work with the histotrypsy, we found parameters that created a temperature that exceeded 60 degrees. Unfortunately, there was no way that we could monitor temperature in real time with each experiment, but we trusted what we saw in our preliminary data would be consistent with each experiment.
I see. And there's a question, PD-1 can also be a marker of T-cell activation or exhaustion. Did you directly evaluate T-cell function in this study?
So we did staining for general T-cell expression and Ki-67 to show the replication of those T-cells, but aside from those studies, we didn't look at the effector function specifically.
Great. And so you looked, it was fairly short term, up to 72 hours. Did you look at T-cell functionality later than 72 hours?
No, unfortunately, it was just the 3 time points, 24, 48, and 72.
Great. Okay. Thank you so much. All right. Craig, do you have any questions that you would like to add for any of our panelists?
Thank you very much. And everybody did a beautiful job. Thank you for presenting and being here. I had one question for Dr. Singh about the CD40 antibody as well. It's a soluble molecule, so I wondered if you know much about whether it really stays locally or whether it diffuses, and whether you've looked at any mechanisms for keeping it local.
We did not check how much long it stays locally, but I remember one paper which showed that till 24 hours the concentration is high, then it dramatically reduced, and after 3 days it was very, very less in tumor.
Okay, thank you.
Well,
Great.
Thank you.
Yeah, thank you so much. All right. Does anyone want to generally take question of how they monitored made sure from mouse to mouse what was a successful treatment? Is there any, especially those doing the preclinical studies, did you have any suggestions that you would want to share with the audience? Hard question.
Oh, okay. Well, I mean, obviously, what we try to do is first to achieve a complete response, and then we monitored for the immune infiltrate. I mean, this is how we try to approach the problem. I don't know if that answered the questions.
Great. Yes, I was just wondering, sort of from mouse to mouse, it is really very challenging to make sure in each treatment, because we do see so much difference in, say, fibrosis surrounding the implanted tumor, et cetera, that it can be difficult, can be challenging to be really consistent. But thank you all so much. These were really great talks, and everyone did a wonderful job here of being able to answer questions very quickly in this very compressed session. So I greatly appreciate